Hey guys, it's Charles and welcome to Good Clinical, a podcast and YouTube channel dedicated to showcasing the future of medicine and human health. Today's episode is another in our partnership with Te Titoki Mataora, and today's guest is Dr. Jo Nunnerley. Jo is the project lead for a group developing a novel virtual reality tool for the rehabilitation of patients with traumatic brain injury. Welcome to Good Clinical, Jo. Great to have you.
Thank you for having me. It's great to be here.
We spoke yesterday and I was completely enamored in your project. I thought it was such a cool pursuit. And when we start talking about it, I was like, wow, I am just so blown away by all the interesting things that are happening up and down this little old archipelago of New Zealand. But before we get into the detail of your project, so obviously it's centered around traumatic brain injury. What do we need to understand about TBI to better understand the context of the project and the solution that you're pursuing?
Yeah. Traumatic brain injury is a really big issue for people in New Zealand. So around 36,000 people have a traumatic brain injury each year, and that ranges in severity from what we would call a mild brain injury or a concussion to a more severe brain injury. And the symptoms and the effects of the brain injury very much depend on the damage that's done within the brain. Often it's something like a car accident, a fall, a Lime scooter. It's very simple to have a fall, land on your head, and then set up a cascade of damage that occurs within the brain. Mm-hmm. Depending on whereabouts in the brain and how much damage is done is going to depend on your symptoms, and they can be minor things in a concussion, headaches, blurred vision, lack of balance, and they can range to more severe things like memory loss, lack of attention, executive processing difficulties, loss of muscle strength in the limbs. So it's a really wide range of symptoms that can occur. And I guess one of the difficulties is that for a lot of those symptoms, they're not seen. They're sort of these invisible symptoms that can be difficult for us to assess and measure because they can be quite personal.
Absolutely. It's interesting you mentioned Lime scooters there because I think there was quite a number of injuries, be it TBI or other, fairly grievous bodily harm that led to them being pulled off the streets for a while, didn't they? You see, it was a bit like, I don't know if you were ever up in Auckland when they had these Sal's pizza guys running around on segways for a few years, and they were screaming through, these condensed streets full of people. And you're like, man, this is just a recipe for disaster. I suppose the Lime scooters were the same. Gosh. So, yeah, it's interesting that you talk about the symptoms being kind of invisible. And I suppose there would be a massive adjustment for a patient that has experienced a TBI, getting used to a new status quo on the way to recovery, or maybe it's just the new status quo forever, right?
Yeah. And I guess one of the tricky things about a brain injury is that there's often a lack of insight that comes along with those changes. It's often hard for people to recognize changes within themselves and sometimes see and understand the signs and symptoms of what things mean. And there are a lot of other additional problems that come along, so secondary problems. And I guess I mentioned fatigue because this is a really big issue for lots of people with traumatic brain injury. So up to 75%, depending on which piece of literature you read, of people who have a brain injury have problems with fatigue. And around half of them consider fatigue to be the most impacting secondary complication that they have as a result of their injury.
Right. Is that physical fatigue or is that more the mental fatigue?
It's both, but I guess
Hmm.
it's the mental fatigue that is often the one that is not as obvious to
Mm.
people, and that the people with brain injury themselves often describe that as the most debilitating. This sort of deep fatigue that isn't resolved by going and having a lie down, which often those of us that don't have brain injury will be able to sleep off that
Hmm.
feeling of tiredness. People with brain injury often describe it as like walking through mud or a fog that comes through that stops you being able to think properly, and can have sort of impacts then on all the other symptoms that they're experiencing, just an sort of an additional layer of difficulty on top of the problems that they already have.
Yeah. And for most of these patients, what's the normal status quo in terms of their rehabilitation? And is it, I mean, surely it's dependent on the mechanism of the injury, the part of the brain that gets injured. You also referred to a cascade of damage. So there's obviously not like the primary locus. It might be other parts of the brain that get secondarily affected. But in aggregate, what's the kind of status quo for the rehabilitation for patients with TBI?
So for most people who have a severe brain injury, they will arrive at a hospital via an ambulance, and they will be treated at their local hospital. And then in New Zealand, we have 3 inpatient based rehabilitation centres. So one in Auckland and one in Wellington, that are run by ABI Rehabilitation, and one at Dunedin Hospital. So patients will transfer to one of those 3 rehab
Hmm.
centres for a period of rehabilitation. And that sort of the length of the rehab will depend on how severe the injury and what their goals are. And then they will transition to their local area and continue with community rehabilitation. And that can be, again, an extended length of time. So often for those severely people with severe brain injury, we're talking months, and they'll,
Mm.
even years of rehabilitation. For people who have concussion, there are, more streamlined pathways, and they will often go through the emergency department or their GP, or if it's a sporting injury, they may be assessed by a therapist on the sideline, or by a team therapist, and then go through. We have very good services in New Zealand available for people who have concussion, and they'll
Mhm.
be referred through to one of those.
Right. And where does the status quo, shall we say, fall short? What are the main sticking points that get in the way of someone's rehabilitation from a traumatic injury like this?
So I guess we're very lucky that we do have excellent services, but there are some inequities in our services. So we know Māori and Pacifica are more affected with TBI, so that they have traumatic brain injuries in higher numbers, and they do not appear to always access services at the same level.
Mhm.
And also, people who live rurally don't always get the same access. We only have 3 TBI centres, so if you're not in one of those centres, you have to travel. And
Mm.
then, although we have excellent teams providing community rehabilitation, depending on where you are, there may be some distance between you and the service, or the service coming to you, which will make I guess the intensity and the ease of receiving those services more complicated.
Yeah, absolutely. I mean, that's not unique to a situation like this, right? I mean, the as time goes on, you kind of feel as though there's a metropolitan elite, and then the regions get underserved, whether it's access to anything medical. There's a Mercy Hospital have just put a PET scanner on a truck, to provide imaging services to the regions, because up until then a PET scanner was only available in I think 2 locations throughout the country, which seems a bit crazy in itself. So that's really interesting. But why don't we So it's a really great summary of the context that we're dealing with TBI. So why don't we pivot to the project that that you are leading? So the virtual reality tool for the rehabilitation of patients with TBI. I got it right that time. Yeah, for those listening, I got it very wrong in the intro first time around. But so what inspired? First of all, what is it? And then maybe we can get to what inspired the genesis of this project.
So our tool is a virtual cafe. So it's using 3D goggles. A person is completely immersed in a cafe environment, and it's supported by a therapist who's watching what's happening on a laptop. The person in the cafe does what we would normally do when we go to a cafe. They look at the menu, they order food, they have conversation with their friends, and we've incorporated some other memory and executive functioning type tasks into the environment, and the varying levels of complexity and cognitive load, so that we can make things sort of easier or more difficult. And we've added lots of distractors and noise to simulate a busy environment, but also to really try and amp up and activate fatigue in people so that they're doing tasks in a fatiguing environment.
Right. With the express purpose of monitoring their progress or making them more familiar with going out in public and feeling that fatigue in real time. What's the main, like, where was this reside in like the grand pantheon of the rehabilitation program for
So
these patients?
it's a great assessment tool, but it's also really useful for teaching and practicing strategies that people need to cope with some of these impairments that they're left with around memory, conversation, dealing with fatigue, and managing their symptoms in a busy environment.
Yeah, because I suppose it's getting getting accustomed to the new status quo as a patient with a brain injury, right? If you're more easily fatigued or more easily distracted by something, or you can't recall something. You mentioned yesterday it's a low risk or no risk environment in which to practice, rehearse, get comfortable with the new status quo. Is that kind of accurate?
Yeah, for a lot of people who've had a brain injury, actually going out and having a coffee is no longer a simple, easy process. They have to remember that they're going out for coffee. They have to get to where they need to go. They have to have conversations with people. They have to remember orders. They have to put up with all the noise and distractions. And there's also often an anxiety about being back in a public place. That, as you alluded to, you no longer quite feel that you are the same person that you were before, and you're quite anxious about making those mistakes. Sometimes when you know that something's difficult, you know there is that anxiety about going and doing it and worrying that you're going to do it wrong. And part of rehab with someone with a traumatic brain injury is often about getting them back to being the best person that they can be. And for all of us, being out in the community is, that's what brings us joy. Going out with friends, going out with family, and if you're not able to do that, that's a big thing. So people want to practice those social situations, but it's a bit tricky to always to facilitate that. And then also, if you get there, I think I said to you yesterday, you get there and the local Plunkett group is happening to have the meeting at the next table, that can be that extra noise, that environment can be difficult for people to deal with. And a lot of us don't like going out and failing at something. And if you go out and fail, then it's so much harder to go back and do it again. So the virtual environment is great that we can adjust that complexity. And also, if someone's getting anxious or there's a problem, we can just take the goggles off and we can talk about it, and we can stop and start and practice, and questions can be repeated, and it can, at the worst, we take the patient for a coffee in the as part of the session, and it's all relaxed. But if something goes wrong in that outside environment, it can be quite traumatic for them and difficult to deal with.
Yeah. So that's again, like I think you said rehearsing those situations, so you're familiar with how you were going to respond in this kind of new version of you, whether it's temporary or permanent or a variation of that, to become adjusted. So in a low risk or no risk environment, so you can practice and get comfortable with this new status quo. Because the alternative would be kind of getting a whole host of people together and manufacturing a setting that way, which is not exactly feasible to do, but a virtual version of it could be. So if, say, I'm a patient with TBI, I would come into, is it a physiotherapist office? Is this going to be used by doctors, nurses, physiotherapists? Is that the idea in that kind of setting?
So the tool was designed by a range of allied health professionals to be used with them. So we've the trial that we've done included speech and language therapists, psychologists, occupational therapists, and physiotherapists, all using the tool with patients to work on slightly different aspects and approaches of very similar problems.
Right. Okay. So that really calls in how important it is to get all the different disciplines together in the development of such a tool, so you have their needs from a clinical sense met, so it's actually useful, has utility in the clinical setting. If you just listen to one party, it's like, well, that's cool, but a patient is going to see a variety of different other clinicians who also need to be considered, right?
Yeah.
So I'm a patient. I'm seeing a physiotherapist or a speech and language therapist. I put the goggles on, and the virtual environment has been set for a particular, shall we say, like difficulty level, complexity level of the task, and that can be adjusted based on how I perform, or based on what the outcome the clinician is looking for. If we really want to kind of push the boat out a little bit and really test the patient, or just get a baseline, all these kind of different things can be modulated to get the best out of the setting.
Yeah. So we've used it. It's been used in a range of different ways. So for some clients, it has been that they have really had no awareness of their fatigue management. So the clinician has really ramped up the difficulty level, essentially so that the person will nicely fail in a supported environment and realize that they actually aren't able to do the things that they think they can, so that when they try to remember 12 orders or 6 orders, they realize that they can't do that. And then the tool can be used in a range of ways. So the clinician can stop the tool and talk to the patient and say, so you seem to be struggling with that memory task. Why do you think that is? Have we been working on any strategies around memory that you think might be useful? And so often with a memory strategy, it can be as simple as writing something down when you're told it. So one of the clients, when we tested it, really wanted to get to the next level of the system and couldn't, because they just couldn't remember all the orders. And then they went, right, I'm gonna write them down. So wrote down all the orders, actually managed to remember them, and then was like, yeah, this is quite a useful strategy. I might use this more often. So, they can
Right.
actually see where they're having problems, see how the strategies can actually be used.
Yeah. Well, that's phenomenal. That must have such utility for a patient and a clinician alike. So you're coaching them through the situation, providing them with strategies to manage a complex scenario, but the clinician, guided by a clinician who's getting feedback from this system. And I can imagine over the long term, you can also manage or assess a patient's recovery by seeing how, there's, I don't know if it's scores involved, it sounds, it's not like a role playing game or anything, but over time you can see how their responses to the different situations change.
Yeah.
I can imagine. So you can, yeah.
Yeah,
How cool is that?
And we do have some scoring. That was a thing that came across strongly from both the clinicians and the clients when we were designing it. Is that they wanted to know what their score was and how they were doing it, and so that can also be help build someone's insight when they like, how do you think you did? Oh, I did great. Well, you got 4 out of 12. Like,
Right.
yeah.
Yeah.
Or it is that they it gives them motivation to keep practicing those skills so that they can see their scores improving.
Yeah.
I got 11 out of 12 this week. This is great.
Yeah. I was thinking that must be such a good positive feedback loop for a lot of people where they can kind of see we all want to get our numbers up, whether it's, as silly on like Facebook friends or LinkedIn followers or a score on, I don't know, those language apps that you learn. If there's a score, we just always want to improve. It's a nice little positive feedback loop there. I suppose during the course of this, the development of this project, you mentioned that you had a bit of an experience that really helped provide additional insight from a patient's perspective that really informed a lot of what's going on here. Can you talk us through that a little bit?
Yeah. So we'd gone through a couple of stages with our product. So we'd done our initial co-design and we'd done some early testing, and we were just looking at how we could adjust some of the settings and maximize the use of the tool. And I actually had a stroke myself, so I woke up one morning and went into the shower as you do, and then I had this blurred vision and I suddenly lost the movement in my right arm and leg, and I was like, oh, this isn't good. And I wasn't a great health professional. I was like, no, I'll be fine. But my partner fortunately was very sensible and took me to A&E, and I had the great clot busting technology and was very fortunate to make a good recovery from my stroke, but really was suffering a lot with fatigue afterwards. And ironically, we designed the tool as a way to identify and treat fatigue. My background is physiotherapy. I've worked in neurology for a long time. I've done helped teach people strategies to manage fatigue, and I thought I had a really good understanding of what fatigue was like until I got to experience it personally. And it gave me such a good insight into lack of insight of the fact that I, even knowing all the strategies and knowing what I should do, I often didn't see the signs that I should pick up of being fatigued. And so the tool was really useful actually as we were developing it, because it kind of helped teach me some of those insights and make me realize those things that were actually triggering my fatigue and helping me notice them before it got to the stage that I was completely, this is me, I can't do any more.
Right.
And I could go, actually, I'm going to need to go and have a rest and a bit of a sit down and get rid of
Yeah.
the screen time. And I still can't sit through the highest level of our virtual program without finishing it. And I'm just like, I need to go home. I'm so tired.
Right. So while developing this program, you kind of one of the first patients, shall we say, to use it in some regard.
It was quite validating to appreciate the difference that having people with the lived experience makes when you're designing the tool, because I think even as clinicians we see it, we know how to help someone through it, but actually feeling it and experiencing it is a different level. And so it was really I've always, as part of my research, always included lived experience partners to really try and improve the quality of the research and make sure that their voice is heard in the research. And so it kind of validated to me the importance of that.
Yeah. Man, that's very inspiring. I have to say, it's really interesting. So why don't we talk about the commercialization journey to date? Obviously, this project is in partnership or in support from Te Titoki Mataora. Can we talk about how it went from idea to assembling of this multidisciplinary team to creating the technology and the support that TTM provided?
Yeah, I guess I think TTM have been instrumental in the development of this project, and their grant structure really helps to move you through the different stages of the project. So from the smaller grant where you can get your team together and start thinking about the feasibility of the project. So for us, that was having an Oculus Rift headset and thinking, this is a great tool, and there's such potential in virtual reality now that you can actually carry virtual the equipment in your hand rather than having the whole screen room set room with screens all the way around, and the portability. And we could see the potential that it could have, and we had some ideas, but that initial grant funding was used to get a group of clinicians from the Laura Ferguson Trust, myself from the University of Otago, at the time, Marcus, an engineer from Callahan, and there were actually software engineers from Cerebral Fix. They're sort of used to producing video games and not sort of medical tools, but sitting with this headset and saying, what can we do? And then getting clinicians and people with a lived experience to say what it was they needed from rehab and what they thought that tool could offer. And the strong narrative that came out from both those groups was social situations are the hardest to deal with and the hardest for clinicians to go out and work in. So we want it to be a social situation, and the biggest issue that we had, the people who lived experience, is the fatigue, and trying to get people to understand what that feels like to us, and for clinicians being able to help people to identify fatigue and to try and measure it in some way, because it's very subjective. We have limited tools to be able to say how fatigued someone is, or if their fatigue is better other than their subjective feedback.
Yeah. Um, Now, can you talk me through why the cafe setting was chosen as opposed to like, sitting down and playing chess or, doing a grocery order or something like that?
So
Um,
we talked. So the ideas came up from the clinicians and the people with lived experience, and there were initially some thoughts. The suggestions were, supermarket setting, going out for a meal, going to a bar, and the cafe. And the thing that was important about the cafe was the sort of interactions on two levels. So interactions with people you knew and interactions with strangers. So with the waitress, and the noise and the distraction that goes on in those social situations. And because brain injury can happen to anyone, so whatever the age or the kind of, I guess, the group that we all think about is the young males. We wanted from the settings that they came up with, the cafe seemed the one that ticked the most boxes, but was also the most relatable for a range of age groups and ethnicities and backgrounds. Most people will go to a cafe at some point, whether it's with work or with family or friends. So it was a very relatable background, and we based our system on the cafe that the Laura Ferguson clinicians take their clients to when they want to practice going back into sort of that community setting. So it was a real, kind of, it ticked a lot of boxes, and it was somewhere that the clinicians would often go with clients.
yeah, that's so interesting. And what's next for the project? I imagine for something like this, you would need to validate the utility as a assessment tool or rehabilitation tool long term. Would that be by means of clinical trial, or what's next?
Well, we've done some small clinical trials, not flash randomized clinical trials, but using the tool as part of normal clinical care in a group of matched clinicians and people with brain injury, and we've had some really good results with that. So our next steps are to really develop our system into a sort of that minimal viable product, smooth some of the edges, and then look at a bigger trial and trying to introduce it into clinical care first in New Zealand, and then dreams of
Take it to the
taking over
world.
the world. Yeah.
Yeah, absolutely. Well, I mean, the world definitely also could make use of such a tool, right? It wouldn't be exclusive to New Zealand, but perhaps the cafe setting might need to be optimized for different cultures or different locations.
Yes. Yeah. We're,
That's super cool.
we've also doing some more work around trying to introduce some AI and some better conversation into the avatars. We have a grant to do some research for that, and also to look at introducing maybe some more objective measures as the headsets for virtual reality have improved, and we're now able to monitor heart rate and eye gaze and things. So integrating those into the system to, see if we can
Wow.
make it even better.
Yeah, you could collect so much data. You have a timestamp of all the metadata of the human being during that experience, and you can compare that through time. Be very, very cool. Wow, Joe, that's such interesting stuff. I really hope nothing but the best for you and your team for the further development of it. I was going to say, if I'm ever down in Otago, I'd love to be a guinea pig just to have a play around with the headset. Obviously, I'm not a patient intended to use it, but it sounds like such a cool project that you're working on.
Thank you.
Yeah. Where can people go to find out more about yourself or the project and what you're up to next?
So we information is available on the University of Otago website. My details are on there. I'm also on LinkedIn. We're going to be bringing the tool up to the Health Tech Conference next week for people to have a go on in the showcase. So we're trying to sort of find places for people to come and have a look at the tool.
Awesome. Well, Jo, thank you so much. It's been really, really interesting. I know people will get a lot out of this episode. Thank you again.
Thank you so much.
Rest of your day.